The guest on this podcast episode has no disclosures to declare.
Hello, everyone, and welcome to another episode of JCO After Hours, the podcast where we get in depth on manuscripts published in the Journal of Clinical Oncology. I am your host, Shannon Westin, G1 Oncology extraordinaire, and also the social media editor of the Journal of Clinical Oncology. And it is my great pleasure to present some really incredible work today that is going to be a dual publication in the Journal of Clinical Oncology and a presentation at the American Society of Clinical Oncology annual meeting on Monday, June 3rd. And this is the ECOG Akron EAZ171 prospective validation trial of germline predictors of taxane-induced peripheral neuropathy in Black women with early stage breast cancer. And I am joined today by the senior author on the presentation and the primary author on the manuscript, Dr. Bryan Schneider. He is the Vera Bradley Professor of Oncology, the Professor of Medicine and Medical Molecular Genetics at the Indiana University, Melvin and Bren Simon Comprehensive Cancer Center in Indianapolis. Welcome, Dr. Schneider.
Dr. Westin, thank you for having me on today.
We're so excited, and we're really excited to really summarize this incredible work that's being presented today. So first, let's just level set. Can you speak a little bit about peripheral neuropathy and, the most common causes in patients with cancer?
Yeah, I think for those of us who treat patients using the taxanes, we recognize probably one of the most important and common side effects that we deal with is peripheral neuropathy, and one that can, I think, impact both quality of life, but also impacts the ability to maintain dose intensity. When we think about risk factors for neuropathy historically, I think obesity has been reported as a potential risk factor, as has diabetes and other conditions which put people at risk for neuropathy.
And prior to your work that you'll discuss with us today, what do we know about the incidence of peripheral neuropathy in patients that identify as Black?
Yeah, so interestingly, I think we've recognized that patients who self-identify as Black have disparate outcomes in terms of inferior survival and more aggressive subtypes of breast cancer like triple negative breast cancer. But I think the idea of toxicity being a disparate factor as well is probably a more recent one. Interestingly, as we set out to identify biomarkers to predict outcomes in the large adjuvant trial E5103, we weren't really setting out to look at this by race. We were using at that time genome-wide approaches to identify biomarkers for toxicity and also efficacy. But what was interesting is we did that. One of the most important predictors as we looked across a number of important toxicities was ancestry. And really, the science spoke to us. It was very clear that patients of African ancestry had higher rates of BEV-induced hypertension, anthracycline-induced cardiomyopathies, and also peripheral neuropathy.
That's so interesting. We have so much overlap in gynecologic oncology and breast cancer. And I don't know that I've ever seen work like this. And now it's making me very intrigued and making me want to move forward to that. Can you talk a little bit more about this ECOG Akron E5103, like briefly about the study and what it demonstrated specifically?
Yeah, so E5103 was an adjuvant breast cancer trial that really set out to look at the impact of bevacizumab in the curative setting. So this was a 5,000 patient trial that randomized patients to standard backbone of chemotherapy. So everyone received 4 cycles of doxorubicin and cyclophosphamide, followed by weekly paclitaxel, and then with or without the addition of bevacizumab. So the parent clinical trial showed, as we know now, bevacizumab didn't add benefit. But certainly this was a fertile ground for us to use genomic markers to try to identify a number of other important factors and predictors.
And what did you find genomically in that study that led to kind of where we are now?
Initially, what we found is that ancestry was a major predictor of neuropathy. And in that trial, we saw essentially a doubling of the risk of grade 2 and above and a doubling of the risk of grade 3 and above neuropathy. When we then looked comprehensively across the genome for common variants that might put patients at risk for neuropathy, we had enough patients in the Black population to identify some markers that seemed to differentially predict the risk of neuropathy in the patients of African ancestry. So there we found a variant in the gene FCAMR, which appeared to be protective from neuropathy, and FKMR is known to have an immune modulatory effect. But importantly, we also found that rare variants, so we did this using an exome-wide approach, in a gene called SBF2 predicted an increased risk of neuropathy. Now, interestingly, that gene SBF2 is also thought to contribute to a hereditary form of neuropathy, Charcot-Marie-Tooth. So here what we found, obviously, is that if you inherit two of these variants, you probably have a hereditary neuropathy. But if you inherit one, you may not have neuropathy at baseline, but if exposed to a neurotoxin, much more predisposed to that event.
That is so intriguing and makes so much physiologic sense. So can you talk a little bit about how that led to the development of the current study, the objectives, design, that type of thing?
Yeah, so I think overarching question and concern is, and we see this with all clinical trials in the United States, is that we're seeing disparate outcomes in a population that are largely underrepresented in our clinical trials. And so one of the first things we wanted to do was really focus in on the population that were being disparately affected. So EAZ171 was set out to accrue patients, and in fact, only accrue patients who were self-described as of Black race or African American. So the goal of this trial then was to see if, number one, we could further predict which patients were going to get neuropathy based on our germline genotyping, and then also to better personalize the type of taxane based again on genomics, but also on the risk of dose reductions, risk of neuropathy, impact on financial toxicity, quality of life, and a number of other what we felt to be important clinical variables.
So let's get into the details. What did you find regarding the incidence of neuropathy in the study, and how was it impacted by the type of chemotherapy the patient received?
Yeah, so the starting point, the primary objective of that study was to try to validate a high and low risk composite score for neuropathy. And the trial was negative, meaning our genotypes did not predict significantly differences based on the germline genotyping. Now, interestingly, the genotyping did numerically separate, meaning those in the high risk category had about a 12% higher risk of neuropathy, but this did not meet statistical significance. Another major or key secondary endpoint, though, was to look at the type of taxane and its impact in this population. And indeed, what we found is that patients who received paclitaxel had a markedly and statistically significantly higher risk of both grade 2 and above and grade 3 and above peripheral neuropathy. And in addition, we saw more dose reductions, both because of TIPN and all causes in the paclitaxel arm.
So why do you think you were unable to validate the genomic predictors in the current study?
This is an incredibly important question. So number one, we were happy to see the directionality of our preliminary data be correct. But I do think that neuropathy is a very complicated toxicity, and it's probably a multigenic effect, and it probably is also impacted a lot by a variety of clinical factors. So some of the future work we'll be doing is looking at polygenic risk scores and other known genes that may be impactful, and also melding that with a number of really important clinical variables, because I still think we have the potential to predict this ahead of time.
I know that this was such a patient-driven topic, really focused on the patient experience and how to improve not only survival outcomes, but also toxicities and quality of life. Can you speak a little bit about the role of patients in the design of this trial and maybe with helping it be as successful as it was with accrual?
Yeah, this has truly been one of the most exciting projects I've ever embarked on, and largely because of the incredible team atmosphere and contributions by so many people. Real thanks to the late Warda McCaskill-Stevens and also the late Edith Mitchell, who were two really fundamental disparities experts who really helped motor this trial to where it was. And also our patient advocates and the community at large really were part of the design and part of this from the very beginning all the way through the publication. And I think have made it a clinically relevant study, and one that I think we're all very proud of.
Is paclitaxel typically what is the go-to, or are more people using, let's say, docetaxel?
I think it depends a little bit on the disease setting and type, and again, is a function of historical clinical trials. One of the pivotal trials, E1199, actually compared a number of these. So it compared weekly paclitaxel to every 3-week paclitaxel to weekly docetaxel to every 3-week docetaxel in a 2x2 design. And essentially, the conclusion there is that weekly paclitaxel and every 3-week docetaxel both outperformed what at the time was the standard of care every 3-week paclitaxel. Now, weekly paclitaxel, at least through ECOG-ACRIN, has been adopted as kind of the standard reference therapy and schedule of choice, but largely because of the side effect profile. And again, this is based predominantly on white patients where the tolerability is much better.
Well, I mean, I think that this leads to really great information around how we're designing these trials and how we're potentially making those differences. What are your next steps here?
So I think one of the things this clinical trial did was first validate that we do see high rates of peripheral neuropathy in Black patients with breast cancer. This was a prospective study using both physician and patient adjudicated variables. So I think this is a really nice validation that this is a problem in this population. I think it also shows us that docetaxel is probably a more tolerable drug for Black patients with breast cancer. The goal, though, I think in our future work is really going to try to bring equity in terms of outcome and side effects. So we're working with ECOG-ACRIN now on our second trial, where really the primary endpoint is going to be to nullify the disparities and try to bring equity in terms of toxicity. One of the other pieces of work we're really excited about is we're doing some ex vivo work. So from patients in EAZ171, we have a blood stick where we're taking white blood cells and differentiating those into peripheral neurons. And here we're hoping to look at really important changes in both gene expression and epigenetics that might lead us to a little bit deeper understanding of the mechanism of the disparities in neuropathy, maybe what's causing some of the neuropathy. And we hope ultimately these may lead to nice drug targets to help prevent or treat neuropathy down the road.
Those are some really great ideas. You know, the other thing that really caught my eye around your findings was what you all found regarding the physician-reported and patient-reported toxicity. I'd love for you to kind of summarize that, because I think that's always a concern as well.
Historically, I think we recognize that physicians probably underreport side effects. And so we felt, and our team felt, that having patient-reported outcomes would be a really critical piece to this study. What was fairly astonishing to me, if you look at the CTCAE, both patient and physician-reported outcomes, they were actually pretty similar. And I think what this is a testament to is if physicians are actually thinking about the side effect, they do a pretty good job of predicting it. Now, one thing we're looking very forward to is that we have long-term follow-up out to 3 years. So it'll be interesting to see if physicians continue to pay close attention to neuropathy, because I know the patients will be. So we'll be looking at the discordance at these longer-term follow-up time points as well.
Well, great. This is such incredible work. And I'm like literally taking notes to get in touch with people I know that do this type of work in gynecologic malignancies, because I think that this is going to have far-reaching consequences. So just thank you so much for taking the time to review this, and congratulations on the JCO publication and ASCO presentation. It's very well deserved.
Thank you, Dr. Westin.
And thank you to all of our listeners. Again, we have been discussing the ECOG-ACRIN EAZ171 prospective validation trial of germline predictors of taxane-induced peripheral neuropathy in Black women with early stage breast cancer. We're so grateful you joined us, and please do check out our other offerings wherever you get your podcasts. Have an awesome day.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.